So before we actually get on to what cardiac tamponade is and how you treat it, I think it might be useful to just go over the absolute basics of physiology, because actually tamponade is a fairly simple thing to understand, and it'll make a lot more sense if we just think about the basic physiology that's at play here. So if we draw our heart out like so, and then we just try and think about what's actually happening in the heart during diastole and during systole. So what's happening in diastole is that blood's entering the right atrium, yeah, the SVC and IVC there, and blood's entering the left atrium. And if we mark that as diastole, and blood's entering from the right atrium to the right ventricle, and blood's entering from the left atrium to the left ventricle. And in systole, what's happening is blood's coming out of the right ventricle and blood's going out of the left ventricle. So that's all pretty straightforward. What I want you to try and think about is that tamponade fundamentally is an issue with diastole. It's not a problem of systole, it's a problem of diastole. So why is it that diastole more important than systole when it comes to tamponade? Well, it's a really simple thing. You've got a pressure from outside the heart pushing all the four chambers. So let me just ask you a question, and you think about the answer before I give it to you. Which chamber of the heart has the lowest pressure? Let's make it simpler. Right side or left side? Between the right side and the left side, which side is under a lower pressure? And obviously, it'll be the right side. The left side has to supply the whole body, the left ventricle, and the right side has to just supply, the right ventricle just has to supply the lungs. So the right side, just by sheer logic, would be a lower pressure than the left side. Okay, so between right atrium and right ventricle, which one is under lower pressure? It's the right atrium. So one thing that's clear is that the pressure that's lowest in all of the four chambers is going to most likely be the right atrial pressure, yeah? So now let's look what happens when we have a patient with a large pericardial effusion or a significant enough pericardial effusion that it causes a cardiac tamponade. What's happening is you've got this pressure from outside the heart pushing in on all of the four chambers. The very first chamber that's going to feel that pressure is going to be the right atrium. And what will end up happening is you might see certain signs of tamponade, early signs that might be described on an echocardiogram as right atrial collapse. You might see things like that on an echocardiogram, which will tell you early on that there is an external pressure, and the very first chamber that'll feel that pressure, which can actually be detected on echocardiogram, will be the right atrium. Okay, and what's the surrogate for that you might see at the bedside? A good surrogate marker that you will also find is that the JVP will rise, because the JVP, the jugular venous pulse that you're seeing, is literally just a straight column of blood that goes from the jugular vein, which you're looking at, the internal jugular vein, all the way down to the right atrium. One interesting thing about the JVP is that there is no valve there, which is why it's such a good surrogate marker for right atrial pressure. All the JVP tells you is that the right atrial pressure is elevated. In tamponade, you will often find, well, you will definitely find, that the jugular vein, a venous pulse, is elevated. So JVP will be up, and that's what you'll see at the bedside. Okay, so that's one of the earlier signs that you might find, is that the JVP rises. The other signs you'll find is that if you have inadequate filling of the ventricle, because there's inadequate filling of the atrium in diastole, then you're going to get a drop in your cardiac output, because your cardiac output is directly related to how much blood's actually entering the ventricles, right? By Frank-Starling's relationship, your contraction pressure, your stroke volume, everything will go down because there's just not enough blood entering the ventricle, because there is basically a diastolic failure going on. And there's diastolic failure because diastole is dependent on blood going down the pressure gradient. But if you've got this increased pressure around the heart, your heart can't really fill properly. And if it can't fill properly, then systole will suffer as well, and you'll actually start dropping your cardiac output. And you're doing that because there is a problem of the heart not being able to fill in diastole because of this external pressure from this bag of fluid that's surrounding the heart on all sides and compressing it. Why don't we talk signs and symptoms of tamponade? Let's start with symptoms, what the patient actually comes to hospital complaining of. The earliest symptom the patient may find that they'll actually start complaining about is shortness of breath on exertion. They'll find they're just getting more and more breathless doing things. They'll find generalized tiredness. All of these signs are basically because of a drop in cardiac output. So fatigue, tiredness, shortness of breath on exertion. Generally speaking, in a cardiac sense, we find that climbing uphill or climbing stairs becomes a real problem. And that's what patients start feeling, is that, that's weird. I could climb 2 flights of stairs easily normally, but now suddenly it's becoming a little bit difficult for me to do so, which is a bit unusual. Corresponding with that, the signs you'll find that the patient's tachypneic, so they'll be breathing harder. You'll find that as they have tamponade worsening, they're going to get more and more tachycardic. And the reason they're getting tachycardic is stroke volume's dropping. Then to maintain cardiac output, they're going to increase their heart rate, because stroke volume times heart rate equals cardiac output. So if you drop your stroke volume, you increase your heart rate to try and compensate. Then you're going to basically activate your adrenergic drive, which will be as a compensatory mechanism to increase your cardiac output. You'll notice the patient's JVP will be elevated, as we mentioned before, because it's a surrogate marker for right atrial pressure. It's the very first chamber that'll feel it, and your JVP will rise. A late sign, of course, will be development of hypotension. Unsurprisingly, you're dropping your cardiac output. More than that, in the blood pressure, you'll see narrowing of the pulse pressure. The systolic and diastolic pressures will be closer together than you would expect. And that's partly because your stroke volume has gone down. So your pulse pressure is a very, very good marker for stroke volume, which is also seen in aortic stenosis, which also has a similar problem, and a lower stroke volume, because just not that much blood gets out of the left ventricle. Of course, it's a different pathology in aortic stenosis, but in both cases, you have a drop in stroke volume and therefore narrowing of the pulse pressure. Now, for the writtens, I should probably mention Beck's Triad. I have to say, it's not a clinically very useful sign. You don't see it mentioned that much on ward rounds or anything, mainly because its pickup rate is around 50%. So you could just flip a coin and be just as right as Beck's Triad. But Beck's Triad is classic and is described as hypotension combined with muffled heart sounds combined with swollen or distended neck veins. It sometimes pops up in SPAs. And the final most important sign that you just must be aware of, mainly again just for written exams and sometimes pops up in discussion bits of OSCEs, is pulsus paradoxus. Pulsus paradoxus, so defined basically as a drop in your systolic blood pressure with inspiration of greater than 10 millimeters of mercury. So let's just start by saying that everyone, in normal physiology, everyone gets a drop in their blood pressure with inspiration. This is normal. When you take a deep breath in, you get increased venous return, you increase the blood flow to the right side of the heart, and partly because you've just reduced temporarily the amount of blood that is entering the left atrium, everyone gets a drop in blood pressure when you take a deep breath in. This is normal physiology. Pulsus paradoxus is when you get an exaggeration of normal physiology and you get a greater than 10 millimeters drop in systolic blood pressure during inspiration. The name comes from the fact that during inspiration, basically with a stethoscope, you can hear heart sounds that you can't feel at the radial artery. So if someone with tamponade takes a deep breath in, they will create a negative interthoracic pressure because they're basically trying to get air into their lungs. At the same time, blood will rush to the right atrium because you're increasing your venous return to the heart because of that negative pressure, so blood will just rush to the right atrium. Now, in normal physiology, that blood just enters the right ventricle and the right ventricle expands and just takes it all in and it's not a big deal. But if you have this tight bag of fluid around the heart that's preventing the right ventricle from going anywhere, that blood will force the septum to move towards the left ventricle and it'll decrease your left ventricular filling. Now, your left ventricular filling's down anyway because you're a patient with tamponade physiology. There's not much blood that's entering the left atrium because of this bag of fluid around the heart. And then you decrease the left ventricular filling even more. And what you're going to get is a drop in cardiac output that's even greater. And that's where you get your pulsus paradoxus from. That little bit of physiology I've just explained actually has a fancy name called ventricular interdependence. And it's something very specific for cardiac tamponade. Pulsus paradoxus has actually got an 80% sensitivity for picking up cardiac tamponade in patients with a significant pericardial effusion. So don't forget this sign. It's a really, really important one. A little important thing to remember is that there are lots of other causes for pulsus paradoxus. Lots of respiratory pathologies can do this as well. Classically, obstructive sleep apnea, and you often see it with an asthma attack as well. A nice way to divide this up is dividing up pulsus paradoxus into cardiac causes and pulmonary causes. So cardiac causes are all down to the fact that the right heart is unable to dilate out to the increased right ventricular blood flow from the right atrium, receiving the extra bit of blood from the IVC and SVC. And that can be because you've got this bag of fluid around the heart, so it could be because of pericardial effusion. It can also be because of some other obstruction from outside the heart, so you can get this with constrictive pericarditis as well. You can get this because the right ventricle is actually structurally not able to do so. So it could be because you've got increased right ventricular pressure from a big PE. You can also get it from a right ventricular infarction of some kind. Pulmonary causes for a pulsus paradoxus are down to the fact that you're basically hyperinflating your lungs and you've just got a lot of pressure in the chest, and that's preventing the left ventricle from ejecting blood sufficiently. So things like asthma attacks, COPD, and another classic one, of course, is tension pneumothorax. So how do you treat tamponade? Well, to be honest, I'd expect any medical student to give me the straightforward answer, pericardiocentesis. Basically stick a needle in and drain the fluid out. That's a very basic answer. It's absolutely accurate, and that is the correct treatment for this medical emergency. You have to drain the fluid, and the best treatment for that is a pericardiocentesis. Generally speaking, these days, we do those in the cardiac catheterization laboratory. It can be done at the bedside, but in most cases, these patients get transferred to a big cardiac center, and we do this under fluoroscopic guidance. So we do it with x-rays and kind of just being sure we're in the right space, using an echocardiogram at the same time as well. An alternative treatment could be surgical. You can do a pericardial window, which is the name for the thoracic surgical treatment for this. And now on to the medical management for this. So say you're the junior doctor looking after this patient who's got signs of a cardiac tamponade. The best treatment you can do while you wait is you can start doing sensible things like checking the patient's clotting, because they're going to need to have some kind of invasive treatment. So if you can check the platelets, the INR, the APTT ratio, you can start reversing some of those things. Maybe the patient is on warfarin, you can give some vitamin K. But what else can you do to buy some time? Well, the best thing to do in this situation is give the patient some fluid. Ideally, stick a nice big cannula in and start giving some kind of intravenous volume filling. Because if the problem is diastolic failure, and that means you're not filling the right atrium, then the best treatment is to increase the patient's venous pressure and just fill the SVC and IVC with fluid, and that'll increase your right atrial filling pressure, which will therefore increase your right ventricular filling pressure and give you a bit more of a blood pressure to play with. You're going to basically directly counteract this issue with diastolic failure by increasing the patient's venous volume, by giving them some extra fluid. If that fails, the other options are things that will basically, if the patient goes to intensive care, you can think about giving them some kind of vasopressor, such as noradrenaline or maybe vasopressin, increasing the venous return to the heart, because it'll decrease the amount of blood in the venous circulation, it'll clamp down those veins, and it'll increase the venous blood coming to the right atrium and effectively do the same thing. The absolute worst thing you can do is give this patient some furosemide. Now, I know why everyone went for it. I purposefully asked this tricky question because people, I'm talking doctors who graduate, they often get this wrong. Never, ever, ever give these patients furosemide. The instinct is that because there's too much fluid around the heart, if you give furosemide, the patient will pee it all out. I completely get the instinct, and it's a mistake I would have made as well as a junior doctor, but it's something you need to be aware of just because of basic physiology. If you give this patient furosemide, you're going to make them get rid of extra volume, and all that's going to happen is you're going to accelerate the drop in right atrial filling, which will just accelerate your tamponade, and that'll be pretty catastrophic. Let's talk causes of cardiac tamponade. So cardiac tamponade's happening because you've got an accumulation of fluid in the pericardial space, and that fluid, if it accumulates fast, even with a small volume of fluid, you are likely to get tamponade. Or of course it could have accumulated slowly, and it's just a case that you've got too much pressure in the pericardial space, and that starts obstructing diastolic filling of the right atrium, and you start getting tamponade physiology. So effectively, causes of tamponade comes down to what are the causes of a pericardial effusion. A very simple rule of thumb in this situation is to just remember that around 50% of pericardial effusions tend to be quite small, and you'll never find a cause for them. They tend to be idiopathic. It's almost certainly viral, most of them, but you never really find a cause. For significant effusions, they can be divided into malignant, inflammatory, or infectious. Because malignancy is up there on the list, one of the things that most patients end up with is certainly a chest x-ray and often cross-sectional imaging with a CT scan of the chest to look for malignancy. We have to remember that worldwide the commonest cause is TB pericarditis. We do sometimes see that here as well, of course. We can get pericardial effusions from all sorts of viruses. Sometimes they can be significant. And you can, of course, get pericardial effusions, large ones, with any inflammatory condition. Rheumatoid arthritis and lupus come to mind, but you can get them with almost any autoimmune condition as well. So that's that then. That was a small whistle-stop tour of cardiac tamponade and a bit of cardiac physiology, but we touched on quite a lot of stuff. We brought up pulsus paradoxus, we touched on the differentials of pulsus paradoxus, and we got through cardiac tamponade, its signs and symptoms, and its causes and treatment. You can see why I picked this, because it's often a little bit hard in a single slide to get into these little bits of physiology that explain little nuggets of medicine that you can sometimes run into. I think next what I'd like to cover is splitting of the heart sounds and just try and explain that as clearly as I can, but you guys can tell me if it actually sounds any good. If you do have any suggestions for what you'd like for me to cover, any specific bits of physiology that don't make any sense, then I'd love to try and have a go at that. There's some other things I'm working on which will be fun, and then of course we've got a final year course coming up at the end of the year, which was enormously popular last year, and I'm hoping if you're listening to this and you enjoy this kind of teaching, you will consider coming to it. It'll be a lot more focused, and it's basically designed to be bang, 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 just SBAs, high yield stuff, and then really nailing the OSCE bit and the Q&As that come with it. My goal is basically try and get you guys all ready to get prizes. I just totally believe that doing well in medicine isn't rocket science. It really isn't. It's just all about pattern recognition and understanding some really basic concepts. Everything in medicine comes down to logic, and you can kind of work it all out from first principles. You don't need to learn endless lists, you don't need to learn endless mnemonics, because it's all completely doable. Anyway, guys, have a fun week, and I hope you'll join me for the next one. Peace.